Biochemistry, high yield topics. Glycogen storage disorders. Let us read about glycogen storage disorders. Von Gerke's disease. The findings seen in von Gerke's disease are severe fasting hypoglycemia, increased glycogen in the liver and kidneys, increased blood lactate, increased triglycerides, increased uric acid, leading to gout, and hepatomegaly, renomegaly. Liver does not regulate blood glucose. The enzyme deficient is glucose 6 phosphatase. Treatment is frequent oral glucose or cornstarch, avoidance of fructose and galactose, impaired gluconeogenesis and glycogenolysis. Pompe's disease is type 2 glycogen storage disorder. The enzyme deficient is acid alpha 1,4-glucosidase. It is also a lysosomal storage disorder. Clinical features are cardiomyopathy, hypotonia, exercise intolerance, enlarged tongue, and systemic findings leads to early death. Cure's disease, type 3 glycogen storage disorders. Cure's disease, enzyme deficient is debranching enzyme, that is alpha 1,6-glucosidase and 4-alpha D gluconotransferase enzyme. Gluconeogenesis is intact here. It is similar to von Gerke's disease, but milder symptoms and normal blood lactate levels can lead to cardiomyopathy. Limit dextrin-like structures accumulate in cytosol. Hence, it is also known as limit dextrinosis. Most commonly, it is similar to von Gerke's disease, but it is milder than that. Anderson's disease. It is also known as type 4 glycogen storage disorder. It occurs in the younger age group, and that most commonly occurs in children, leading to hepatic cirrhosis. It is also known as aminodextrinosis. Clinical features. Most commonly presents with hepatomegaly and failure to thrive in early infancy. Other findings include infantile cirrhosis, muscular weakness, hypotonia, cardiomyopathy, early childhood death. Enzyme deficient is branching enzyme. Neuromuscular form can present at any age. Hypoglycemia occurs late in the disease. McArdle's disease. It is also known as type 5 glycogen storage disorder. The enzyme deficient in this is muscle glycogen phosphorylase, characterized by flat venous lactate curve with normal rise in ammonia levels during exercise. Clinical features: increased glycogen in muscle, but muscle cannot break it down. Painful muscle cramps, myoglobinuria with strenuous exercise, and arrhythmias from electrolyte abnormalities. Second wind phenomena noted during exercise due to increased muscular blood flow. Blood glucose levels typically unaffected. Non-ketotic hypoglycemia on starvation seen in MCAT deficiency. Let us now see about lysosomal storage disorders. In lysosomal storage deficiency, accumulation of the abnormal metabolic products occurs. Increased incidence of Tay-Sachs, Niemann-Pick's, and some forms of Gaucher's disease seen in Ashkenazi Jews. Sphingolipidosis. In lysosomal storage disorders, we have sphingolipidosis and mucopolysaccharidosis. In sphingolipidosis, we see Tay-Sachs disease. In Tay-Sachs disease, we see cherry red spot. Enzyme deficiency is hexosaminidase A. Substrate accumulated is GM2 ganglioside. Clinical findings: progressive neurodegeneration, developmental delay, hyperreflexia, hyperacusis, cherry red spot on macula, lipid accumulation in ganglion cell layers, lysosomes with onion skin, and the main feature here is no hepatosplenomegaly. It differentiates it from the Niemann-Pick's disease. It is autosomal recessive inheritance. Next, Fabry's disease. The image shown here is of angiokeratomas. Enzyme deficient is alpha galactosidase A. Accumulated substances ceramide trihexoside. Early features are triad of episodic peripheral neuropathy, angiokeratomas, hypohidrosis. Late features are progressive renal failure and a cardiovascular disease. It is X-linked recessive. Metachromatic leukodystrophy. Enzyme deficient is aryl sulfatase A deficiency. The substrate accumulated is cerebroside sulfate. Clinical features are central and peripheral demyelination with ataxia and dementia. Autosomal recessive inheritance. Krabs disease. Enzyme deficient is beta galactocerebrosidase deficiency. Accumulated substrate is galactocerebroside. Autosomal recessive inheritance. Clinical features are peripheral neuropathy, destruction of oligodendrocytes, developmental delay, optic atrophy, and globoid cells. Globoid cells is the main feature in this Krabs disease. Gaucher's disease. The enzyme deficient is beta glucosidase. We saw alpha glucosidase deficiency in Pompe's disease. Beta glucosidase deficiency is seen here in Gaucher's disease. The substrate accumulated is glucocerebroside. It is also autosomal recessive inheritance. Most common hepatosplenomegaly, pancytopenia, osteoporosis, avascular necrosis of femur, bone crisis, Gaucher cells. Here image shown is of Gaucher cells, lipid-laden macrophages resembling crumpled tissue paper appearance. Niemann-Pick's disease. Progressive neurodegeneration is seen, hepatosplenomegaly, which is differentiating feature from that of Tay-Sachs disease. Here we see foam cells, lipid-laden macrophages, cherry red spot on macula. Hepatosplenomegaly with a cherry red spot. Niemann-Pick's disease, enzyme deficiency is sphingomyelinase. Substrate accumulated is sphingomyelin. Inheritance is autosomal recessive. Next, mucopolysaccharidosis. In mucopolysaccharidosis, first Hurler's syndrome, Hunter's syndrome. Hurler's, developmental delay, skeletal abnormalities, airway obstruction, corneal clouding, and hepatosplenomegaly. Corneal clouding is present in Hurler's syndrome, whereas it is absent in Hunter's syndrome. Enzyme deficient in Hurler's syndrome is alpha L-iduronidase. Substrate accumulation is heparin sulfate and dermatin sulfate. Autosomal recessive inheritance. In Hunter's syndrome. In Hunter's syndrome, enzyme deficiency is iduronate 2 sulfatase. Accumulated substances heparin sulfate and dermatin sulfate. Mild Hurler spreads aggressive behavior and no corneal clouding is seen here. It is X-linked recessive. Now, all lysosomal storage disorders are autosomal recessive except Fabry's disease, which is X-linked recessive. All mucopolysaccharidosis are autosomal recessive except Hunter's disease, which is X-linked recessive. Now, next we see trinucleotide repeat expansion diseases. Mesogenetic anticipation, that is, disease severity increases and age of onset decreases in successive generation. Trinucleotide repeats. All trinucleotide repeats starts with C and ends with G, except Friedreich ataxia, which is GAA. Huntington disease. In Huntington disease, we see CAG repeat, hunt in a cage, hunt CAG, and it is autosomal dominant mode of inheritance. Caudate has decreased ACH and GABA. Myotonic dystrophy. In myotonic dystrophy, trinucleotide repeat is CTG. Autosomal dominant mode of inheritance. Here we see cataract, early balding in males, gonadal atrophy in males, and reduced fertility in females. Fragile X syndrome. Here we see trinucleotide repeat of CGG. It is X-linked dominant inheritance. As it is written here, Fragile X, so X, it is X-linked dominant. All structures are fragile, leading to chin protruding, giant gonads. Next, Friedreich's ataxia. It has trinucleotide repeats of GAA. It is autosomal recessive inheritance. Here we see ataxic gait. Most of the features of Friedreich ataxia are similar to the vitamin B12 deficiency and vitamin E deficiency.